It's much more so in the pandemic agreement, because by definition, it's really not adopted. Though it is formally adopted, the adoption conditional to actually an agreement being worked out satisfactorily on Article 12, which is the PABS article, for which an intergovernmental working group has been set up, for which there are chairpersons and co-chairpersons, and for which the first round of discussions is happening later this coming week. It is happening coming week, and that, I think, is the main text of what Nithin is going to talk to us about, and they are following that. So, what is important to notice that till Article 12 is settled and signed on, the rest of it is not open for signature. So the document has not yet been placed for signature. After it is placed, the individual countries have to individually ratify it. And once about 60 countries, I think, ratify it, then it is within 1 month, it starts getting implemented. So, though we have a resolution path charting the way from the last World Health Assembly, in a very formal sense, the agreement is not signed, and it is not being signed till there are major bottlenecks to be crossed. But that's not the only bottleneck. There are 5 more institutions that flow out of this particular document. So after it is signed, and once the PABS, the pathogen access and benefit sharing, is fine, that is under Article 12. Under Article 19, the conference of parties have to be set up. Under Article 18, a coordinated financial mechanism has to be set up. Under Article 14, an institution called the Global Supply Chain and Logistics Network has to be set up. And Article 5 indicates that may not be set up within pandemic agreement itself, but a One Health instrument has to be set up, for which a deadline has been given, May 2026. So even for some of the other things, there are deadlines given, but for the discussions to start. And they're expecting by 2026 that these 5 areas also we have a negotiated understanding of it. And in some sense, after PABS, the rest can start. But in anticipating the possibility that there will be no signing on, and this is really a thing. There are 2 clauses that says, even though it is not signed on, the preparatory activities must start. So that is part of the adoption, because there are no controversies there. But even if the agreement is prepared, and then it also says, in the interim, that is before everybody signs on, before it comes into effect, if there is another pandemic, we will act as if this agreement has been signed on. Okay, but there will be no enforcing ability anyway. But therefore, it seems that the drafters themselves are not too sure about the process or time it will take for the agreement to actually become part of the global international law. So in what I'm trying to say is that this is very much work in progress. But the attention of where the real rub is on that pathogen access and benefit sharing, which I think I'm going to leave completely to Nithin to handle, because I don't really require. Also because I somehow feel that while that requires attention and a lot of attention has gone to it, many other aspects of this are not in place. Now, what was the overall expectation from a pandemic agreement? Essentially, if I may paraphrase it, it is to make the world safer. COVID-19 was a terrible experience, and we should not have to repeat that experience. And signing the agreement represents a global political will to make the world safer. And therefore, the question with which we will start in any people's movement is, has it become safer? I mean, it's as simple a question as that. And when we are saying safer, we are not only talking of the deaths and the diseases that this will cause, we are also talking of the possibility of lockdowns, the huge degree of economic distress they cause, the huge human rights they cause. Even that should be brought within our ambit, and also the excess mortality. There's something that excess mortality, there is a recognition of that. But unfortunately, on the human rights, except its expression that it should be consistent with humanitarian laws in the inauguration, it gets lost sight of completely thereafter. The human rights angle, health rights is established, but at some point, much of it is really lost on this. So the whole issue of the lockdown itself is obliquely referred to in different provisions. But if making the world safer is making it safer from viruses and lockdowns that happen consequent on the viruses as a response to the viruses, which can be equally have equally deleterious effects, then at some point the agreement has its limitations on that. So when it comes to what are the other things, so I'm saying there are two broad areas where the agreement has not really gone into, and that's sad, but it's there. It is one of it is this, and one of it is in the lockdowns on that. Uh, the uh, if we must make real sense of is the world safer, then we must read this pandemic agreement along with the international health regulations. Because there is something that the international health regulations repeatedly emphasizes and has a full annexure about, which is only obliquely referred to in the pandemic agreement. Yet at some point, without this, you're not going to have much purchase in the pandemic agreement. The pandemic agreement is a non-starter. And that, with regard to health systems, is the notion that the international health regulations has of what is called core capacities. So, in preparedness for meeting a pandemic, there is a commitment in the amended international health regulations that every country shall achieve its core capacities within 5 years. And if some country is not able to, it can take an extension of 2 years, and there is a commitment to help that committee. We don't find that very well articulated in this. And at some point when we are talking, there is some paragraphs on this, but that reference to the notion of core capacities is somewhat missing in this. But the core capacities is important, though the IHR recommendation makes it far more specific to epidemics than earlier. The implicit understanding is core capacity requires a certain degree of universalization of healthcare, at least vis-a-vis your primary healthcare system. That at least 3 points the pandemic agreement also states. That we understand that if we are going to do any meaningful preparedness, we need a primary healthcare foundation-based universal health coverage. That's articulated. So in some sense, there is some mention of it, but this is really very weak. There is no financial commitment. There is not even the binding commitment that the IHR has. Not a binding commitment. It's a time target, that the timeline that the IHR has. But essentially, the point that we really need to make over here is that we don't really have a commitment to universal health coverage. And in many places, we have made this point that an accelerated achievement of universal health coverage with or without a right to health law, and there are many reasons why you will not achieve it without a right to healthcare law, is fundamentally required if we are going to have core capacities, if we are going to have a notion of preparedness to meet an epidemic. Which is referred to here is a preparedness only to refer to the processes of disease surveillance and things. This is not enough for a meaningful all of a country response that you will need to give. So I think this is one major area that I really think that we are missing out a lot on. So what I was saying is that there are a number of areas under discussion, but in this area, it's sort of clinched. I don't think there is any space to open up this discussion on the commitment and acceleration, the financial commitment, the technical commitment, what it really requires, and the critique of why we are not progressing in coverage, that it doesn't have. Article 4, which is health systems, if you really look at it, very critical in the pandemic agreement, is in line with IHR on some of these issues. It talks of collaborative surveillance, it talks of community-based surveillance, it talks of water, sanitation, and hygiene, it talks of routine immunization, it talks of infection prevention and control, which largely, though it should not be so, refers to nosocomial infection in the hospitals. It talks of zoonotic spillover preventions, laboratory possibilities of breakouts from laboratories, vector-borne surveillance, and antimicrobial resistance. It has a sort of very tokenish coverage and talks of determinants in interventions in other sectors. But basically, Article 4 is about public health surveillance. But what one emphasizes in IHR and is missing here is the notion of core capacities. One must again understand, if you are in the business of running public health, if you're a practitioner of public health, you would see the point straight away. No pandemic comes if you want a notification within 24 hours, within 1 week. No pandemic comes announcing itself. They usually present as, let us say, a slight increase in the number of noticed pneumonias, which don't fit a classical pattern, and sometimes they do fit a classical pattern, but in some way different from the other thing, which alerts a person. And once they are alerted, they have to search for other causes. Then only they discover that it's a new virus or a new disease which has come on the block. Which means that if you are not looking at every pneumonia seriously, you are not likely to do an early detection of a new respiratory potential pathogen for epidemic, which is the same thing in vector-borne disease, which is the same thing in other things. So the point one is trying to make is, you cannot put in place something that will detect pathogens of pandemic potential without already developed the capacity to look at across the board surveillance. You can't do it. It's not technically possible. There is some recognition of this uh, in the IHR regulations, and let us assume that it's because of that. But over here, the ship has sailed. I don't think we can really go back to that. But this is the Article 4. Article 5 is the One Health article, One Health statement. It's rather generic in its statement. Again, what it commits to is an instrument that by May 2026, it will say there are 3-4 partners in this game, and there are concerns established. But basically, it's a statement of intent on that. There's actually no operationalization visible, but other than having recognized its importance, it has not really been dealt with over here. Article 6 is a particularly important article because if I'm talking of health systems, all of it is presumably within Article 6. And it says each party within the means and resources at its disposal shall take appropriate measures to develop a resilient health system, particularly primary health care for pandemic prevention, preparedness and response, taking into account the need of equity and in line with Article 17 to achieve universal health coverage. The entire weight of this agenda is on this particular line, and that's rather a heavy weight that it has to carry. Article 17 essentially is talking about international cooperation to help countries which are not able to reach it to be able to achieve universal health coverage. But this whole understanding of universal health coverage is then expanded in 5 clauses, and that becomes repeatedly they couch it by saying for pandemics, during pandemics, with focus on pandemics, etc. And the real simple thing is, if you can't deal with the normal non-crisis time health situation, then you are unlikely to be able to deal with it when a crisis breaks out. So if you don't have, for example, district hospitals are not got ventilators for managing acute respiratory failure, it's unlikely that they can get going when there is a respiratory pathogen around on that. But this particular issue is, and similarly on national health information systems also, they much not to say. But on the positive side, this recognition somewhere is there, much more strongly in the international health regulations, but it is there also. Article 7 is on the healthcare workforce, and many people who have positively committed on this have hailed this as something which is of a step forward, because it touches on the necessity of a workforce, the continued safety and well-being of the workforce, and workers in critical supply chains, a global emergency workforce, and the way migration acts in this whole area. So this is definitely a step. There's again no binding thing, but cross-reference to different areas on this. But definitely, this whole pandemic agreement, if I were to use this to teach students as to what should be an ideal health system and how it should prepare to build a resilient health system, I think this is a good document. Is it good enough to make the world safer? I don't know. But it is good enough to actually cover some of the major principles that need to be understood on that. Okay. Now, I'm not going to take too much longer. I must say that there are certain things that one must really look to on this. There's a set of articles which deal with, wait, just one second. I think I missed this. How much more time do I have?
Another 5 minutes or 10 minutes. It's up to you.
Because I've been. So there are Article 9 to 14 has a set of issues, and I want to flag this in a different way from the thing. So my guess on the Articles 4 to 9, which is 8, which is basically about health systems, is okay, this much we have got. We have got a general statement. We'll have to live with that. We don't have any guarantees, but in combination with IHR, for a government which is willing, there is a good guide. There's little binding on that. But the key in this is really about achieving universal health coverage, accelerating achievement, and linking it to the right to healthcare. But then come to interpreting Articles 9 to 14. Now, there are two ways to read this set of articles. One way, which is, I think, very popular within our movement, is to say that none of it is binding. Fair enough. But look at Article 9. Article 9 in its fourth paragraph says, government-funded research and development agreements publicly include provisions, timely and equitable access to such products through licensing and or sub-licensing, preferably on a non-exclusive basis, affordable pricing policies, technology transfer on mutually agreed terms, publication of relevant information on research and outputs, and adherence to product allocation frameworks adopted by WHO. That's a very well-intentioned statement. And while we cannot agree to expect a big pharma to play any role in this, there is a case for progressive governments in the BRICS formation and in other low and middle income countries to link up with people's movements, health movements, to really try to push this particular agenda of what you can say public pharma, or at least nationalist pharma, if you will have it. I mean, in our independence movement, we had a major role for pharmaceuticals, but there's something like that. And that is the spirit in which one should examine sustainable and geographically diversified production and technology transfer and know-how. Just like India and South Africa took a lead in this TRIPS waiver, though India never really stuck its guns out, but still it took a lead on that. There is a case for these countries in the current geopolitical situation to take a leadership role in achieving 9 to 14. And this is something that I think we should move within our sort of give some sort of dimension to our Indian, all this high talk on patriotism, to look at what we can do in a leadership role or soft power role in encouraging this, because we have the capacity to do this. And Article 11 is the transfer of technology and know-how for the production of pandemic-related help. Again, non-binding. Again, Big Pharma is not going to be a player. But again, there is a scope if institutions and countries imagine, even for example, vaccines. While the vaccines, the mRNA developed in the US, German, Europe did not reach very effectively, China depended completely on its own vaccines. So did Russia. To a large extent, Brazil did. Cuba was able to make its vaccines. And South Africa learned a bitter lesson. I'm very sure that the next thing comes around, they will have developed the capacity on this. And we could make our own vaccines. So eventually, though we didn't fully innovate, but we could make our own vaccines. This is not unreachable. But you can't wait on big pharma to actually do that. I don't see any particular possibility of being able to bind down big pharma into actually agreeing on this. It's much better you use the space to actually look at alternatives to even the thing. And there is a particular scope that arises in a number of countries on that. So I'm not going to go into much greater detail on this, but there are other straws in the wind which are hopeful. For example, affirmation of the Doha Declaration. I mean, these things are needed because, look, this is an area when Trump is questioning everything, anything called diversity, equity, and inclusion. Anybody who says that he is willing to ban universities from funding to it. So sometimes principles that are widely accepted reiterated. And in that sense, and look, finally the US has not signed on also. So there does represent a certain, we should not dismiss what has been achieved. We know that big pharmaceutical will not get tied down, and therefore the countries which depend a lot on their economic dominance through such trade relationships and intellectual property right, which are the Europeans. Within them, Switzerland is a major player, which otherwise does not appear in the list. The Japanese, the Canadians, which otherwise are soft. But when it comes to patents, they are harder than the US also. So these are people who may not actually go through with any further compromise in this, except on the pathogen access and benefit sharing, where they are listen. In here, in these articles, they are closed. But because they are non-binding, they are not really, people should not be, at this point of time, we need not be dismissive of them. We need to be able to think of ways in which the BRICS alliance, or now it's got about 20 countries in it, or other formations can build up cooperations across the third world that can make better use of some of these formulations on them. And that it will require a major role of people's movements to intervene, to support of people whom we are linked to in many of these things. So one can see, therefore, that the way in which bilateral agreements and plurilateral ones, regional agreements, are trying to close these gates. That threat is there. But for many reasons, because of the US acting as a lumpen capitalist, there is a space that has opened up now where we should look at some of these clauses in a different way. But as I said, this agreement, though adopted, is very much work in progress. There are at least 5 major institutions which are required for operationalizing this agreement, on which agreement has to be reached. And the first and the most important of this is the PABS. So I think I'll stop over here.
Thanks, Dr. When you're saying that each country needs to again ratify, uh, is this similar to the framework on tobacco that we have? For those who might not know.
Here there are too many ifs, Gargia. Even
Yeah,
they are saying that we need a further negotiation before it is even open for countries to sign on.
exactly.
So it's not the level at which the FCTC was.
Yeah, yeah.
Okay. And even after it is signed on, the details on at least 4 or 5 important instruments of implementation of this, the supply chain network instrument, okay, the One Health instrument, these instruments are not in place. I mean, they are not agreed upon. If I
Yeah.
may say so, just to for a morale boost or whatever it is, they have just kicked the can down the road on some of the crucial issues. Okay, but we'll have to actually engage with many of these issues in the coming period, and uh, therefore, I would say as work in progress, but that itself is good. No, it's unlike the Dunkel draft when everybody signed on. Thanks to at least all the developing countries, they may be under pressure, but they are more alert. And the Africa group in particular has played a very important role in being able to hold uh, the third world from caving in also.
Sure. So, for those who might not, who joined in late or so on, basically what happened in May was some parts were agreed. Uh, the negotiations that will be happening in the coming days, further issues will be agreed upon, in particular this access benefit, which the next speaker will speak, which is supposed to be agreed upon in May next year. So after that, if it happens by May, after that will countries, uh, you know, can they ratify and take it forward? So we have a lot of time even now. So I'll now move on to Nithin. Nithin has been following the, he's right now in Geneva also, following the next round of negotiations. And sorry, sorry for that. So basically, he's been following the negotiations from day one or even before that, both the pandemic agreement as well as the international health regulations amendments, which has happened parallelly. That's a longer story. We are not touching upon that as of now. I'll ask Nithin to actually first, generally explain what is this access benefit sharing. Some of us might not know it, and then go into, what has his experience been with the negotiations about how this has come up. I think some parts of it we might not record, and then about what is at stake in the coming days. What should be the stand of Global South or public health activists and professionals from the Global South? How should we look at this thing? Thank you. You tell me
Thank
when you
you.
want me to stop recording.
Uh, yeah, thank you. Maybe okay.
I'll edit it out later.
Yeah, sure. Okay, that may be better. Yeah. Thank you, Garkeya, and thanks a lot for to Dr. Sundaraman. It was a very brief, very detailed, and uh, a kind of presentation which everybody could follow and understand the nuances and integrities associated with this new agreement. That is definitely helping us to take forward the discussion now today. I will show a couple of slides. I'll also slightly touch upon the process or the amended international health regulations, because it is going to take off. 19th September 2024, we will have enactment or entry into force of the amended international health regulations 2005, and it is also giving us certain um, trigger points, trigger institutions. As civil society, we might want to understand certain fora where we can engage and take forward some of the work which Sundaramanji was telling now. So let me share my screen. This is always problematic. Why is the group not
If you're
coming?
unable to do it, you just send it to me.
Yeah,
Or to
sure.
oh, it started. Yeah,
Right?
we can see.
Yeah. So, just want to give a very short introduction to international health regulations to pandemic agreement. What happened, as was explained previously, this international health regulations 2005 was in fact was one of the only legal instrument which has created obligations on parties to deal with health emergencies. It was initially, previously, if you remember the colonial times, these agreements were called as sanitary agreements, were basically helping people to do measures like quarantine or lockdowns, etc. Sanitary phytosanitary measures that they used to call, and this was changed in 1969 uh, to the name International Health Regulations to give a little bit more of public health approach. I mean, I wouldn't say even 1969 there was a public health approach, but slightly more better than mere sanitary approach happened in 1969. And in 2005, it was revised once again, where it was actually elaborated all these core capacities which was previously talked about, and how countries have to prepare for a health emergencies. And essentially, there were two sets of capacities: surveillance capacities and response capacities. So countries were obligated to have these capacities by 2008 or 2010 or something. And uh, um, uh, there was international financial support, not through WHO or not through necessarily through international health regulations, but through external multilateral bilateral channels to support development of these capacities in developing countries and least developed countries, etc. What has happened, if you look at it, like there was a significant international funding, around 43 to 48% of international financial flows was on surveillance capacities. And even when it comes to the response capacities, there was very limited funding which was available to strengthen health systems or develop what we call as capacities for equitable access to health products. Either it is, let it be R&D or production or what you call as stockpiling, etc., etc. There was very limited funding available to build response capacities as well. Many of these response capacities will go for building legal documents, policy structure, etc., etc., to interact in Ministry of Health with WHO or international agencies like that. So it's like it was never been in a way genuinely investing in public health systems. So that was one of the concerns which earlier had, and which showed the problems, like even in COVID or Ebola or mpox, etc. What happened, energy emergency was identified, detected, declared, but there was very limited coordination and access to health products. So this document, this international health regulations, is the one which actually allowed parties to internationally declare something called as public health emergency of international concern. And you also know, when you do not be able to do proper response, there is economic disruptions will take place, and it will also hit another round on public health infrastructure or investments. So this was the situation, and this actually exposed the entire problems during COVID-19 very, in a magnifying manner. Previously, it's also like there were around four or five, six, I think, public health emergencies of international concern. That was also kind of telling these issues outside, exposing these problems with the document and with the legal structure. But it was magnified during COVID-19 pandemic. And then WHO attempted to solve this with two sets of legal reforms. One was to amend international health regulations, which was done in 2024. And then there was this new agreement which we just talked about, with pandemic agreement, which was adopted last May 2025. So what did in IHR amendment they do was basically they tried to elaborate a little bit more on the response capacities and response activities. So it actually mandated WHO to ensure health access to health products in developing countries, but specifically, um, and also asked, or kind of, I wouldn't say fully binding, but kind of discretionary and a little bit of obligation on member states to cooperate with WHO. So if WHO decides to do, let's say, like diversification of production or scaling up of production or recommends that, then the member states are under an obligation to coordinate or to do some of these activities in a coordinated manner. So that kind of an understanding, which was previously not existing in IHR, was incorporated. First time equitable access to health products was introduced into a legally binding document in WHO, which is the International Health Regulations, and they did that last 2024. And they was telling like WHO have to coordinate R&D, scaling up of production, managing stockpiles, distribution of products, etc. They also developed these kind of institutional mechanisms, like something called as an implementation committee, which all state parties will be part of it, and then coordinating financial mechanism. Actually, coordinating financial mechanism is like slightly a a craft because basically they're saying we don't have no funds. There are other international funds existing. You can coordinate them, and you can talk to other international organizations, and or this mechanism would help countries to talk to these other funding agencies and try to get money for them. They also introduced a new category called pandemic emergency. Like when COVID-19 was declared as pandemic, there was not a legal declaration. It was a political declaration or a technical declaration by WHO DG. Now they have created a legal declaration so that it triggers off certain actions and consequences. And what actually happens when this is declared is more or less elaborated in the WHO Pandemic Agreement 2025. So what the pandemic agreement did was try to give a lot of things. I mean, what all was explained previously is the basic fundamentals of it. But to summarize it and put it into some key takeaway messages, what they tried was basically to elaborate or give institutional structures to those actions proposed in IHR 2005. I mean, amended 2020-24. So when they say coordinate R&D, you have actually an article on R&D in pandemic agreement, article 9, which elaborates what all activities states can do. Scale up production, diversify production, you have article 10 in pandemic agreement, which explains some activities what states can do. Also like technology transfer under article 11, and then global supply chain and logistic network for distribution or of finished health products. I think also it takes care of a little bit of management of raw materials for manufacturers as well. And in amongst all these institutional structures, it's coming something called as pathogen access and benefit sharing system. We will discuss what that in a minute. And WHO pandemic agreement also talks about like increasing some of these surveillance capacities. That's the politics part of it, in the sense like we know international health regulations was having capacities. There was really good capacities of surveillance when we look at during the COVID-19 time period, the scores of IHR, etc. But the repeated argument from the global north and technical experts in WHO and many of these international institutions managing public health were like, we were delayed in detecting COVID-19, in notifying COVID-19, in determining COVID-19. This is because we don't have proper surveillance mechanisms. We are waiting for human beings to get infected and then get to know about this. We have to reach out at the time when the pathogens start moving within the animal populations, or or when even when it is in the deep pockets of forest, etc., etc. And they used actually a very important concept of health, one health approach, to actually promote this idea of surveillance. And the net outcome of this agreement in that sense, if you look at it, what has happened, most of the things, as Sundararaman sir was telling, it's all soft law, not very binding and legally pushing forward. And it's all focusing now on a system called pathogen access and benefit sharing to deliver something legally binding. Now we will see what the system is and why it can perhaps legally, uh, um, you know, legally try to deliver some deliver some equity in a legally binding manner. So pathogen, before going into pathogen access and benefit sharing system, just two words about access and benefit sharing system. It's a international legal tool or legal concept which helps in developing an understanding that if you are developing certain innovative products or services using biological resources, then the provider country of those biological resources or provider communities, like sometimes these biological resources are nurtured by a farmers community, or it's maintained by indigenous people in some rural locality. So those community or the country of origin or of these biological resources has got right to benefit from that innovation. That's the basic idea of access and benefit sharing system. And it's also like as a response to the COVID-19 colonial systems, where these biological resources as well as non-biological resources were extracted from countries who were colonized. They said that there is full authority, full permanent sovereignty of countries over these genetic resources or biological resources to determine who should access these resources and who should perform certain research or development on these resources, and what are the conditions under which such access or utilization of these resources can be undertaken. So it's fully, the full authority is on the country of origin, and if it is belonging to an indigenous community, then their decision, their ability to provide prior informed consent as well as seek benefits from it directly is recognized. This is recognized under two other international treaties called as Convention on Biological Diversity and Nagoya Protocol. Now, what we see here called pathogen access and benefit sharing system is an adaptation of the same idea into the pathogen world, right? And it's not like people sometimes say how pathogen can be considered as a resource. It's a disease causing agent, etc. I would say, one of us, we cannot simply argue that because a life form is causing, or a biological form is causing a disease, it does not have inherent value in it, right? Like even the vaccines are produced using the same pathogen materials. So it's like you have to you consider pathogen in a way as genetic resource or a biological resource or biological organism which can be used to develop not only health products. It can also perhaps unlock further understandings in genetics, biology, etc., etc. So in that way, it's considered as like a very valuable resource. And when a disease happens, how these resource needs to be shared, or not even disease happening, you are kind of creating a system multilaterally through WHO to share these resources and receive certain benefits out of it. And in
Nithin,
the context of pandemic, yes.
can you give the, tell about the Indonesian story so that people can
Sure.
what had
So
happened
basically,
previously? Yeah.
yeah. So if you know about the avian influenza during 2005-7, right? When Indonesia uh, had the outbreak of this influenza, pandemic influenza. What has happened was the virus strains from Indonesia was taken up by certain pharmaceutical manufacturers and developers. They developed vaccines, and the same vaccines, which were available in Europe or US for a particular rate, it was sold back to Indonesia at a higher rate, in a very, very higher rate. And even I think there was some of the sequences, you generate sequence information from these materials, genetic sequence information, and share it. These were also shared outside, um, uh, outside the laboratories which were handling uh, these viruses at that point of time through WHO. It was in fact even a violation, or like excessively acting. These laboratories acted beyond a guidelines which WHO has given to them. So it was shared, and it was actually it was received by some companies who developed these vaccines, and they basically sold it in a high price. So Indonesia then threatened we will stop sharing any more pathogens or sequences unless we have equitable access to these vaccines. As a result, WHO had undertook a lot of mediation process, etc., which resulted in something called as a pandemic influenza preparedness framework, which is also another instrument, not a legally binding treaty, but a WHO resolution, through which now countries keep sharing seasonal or influenza viruses. Generally, countries are obligated only to share pandemic influenza viruses, but they keep sharing a lot of viruses through these laboratory networks, which is now under this framework of pandemic influenza preparedness framework. They share RSV, they share seasonal influenza viruses, etc. And what has happened? Pharmaceutical companies and developers, etc., has become kind of recipients of sequences and pathogens from the system. They keep providing an annual partnership contribution to the framework. So they total industry used to give, I think, around 25 million for the last 10 years. Now, from the last year onwards, it has become 38 million or something. So it's an industry-based agreement, like that money coming, uh, where the maintenance cost of the laboratories and surveillance, 50% will be put by governments, and the 50% is provided by the private sector or the users of the system. And the users include several types of users, and all of them have come together and they have their own internal arrangement of how that burden of 50% will be shared by the users. So they keep putting this money, and in fact this money has also been utilized by several countries to build surveillance capacities further, which has utilized during COVID-19, etc. So around 133 countries have actually benefited out of these funds to build some of their programs, some of their capacities, etc., which do surveillance. We can go into it how it looks like now. I'm just giving an overall interaction about what does this mean.
You have 10 more
Basically,
minutes.
yes. Basically, we give some genetic resources or genetic materials, and when we give, we obligate the recipients to share back some benefits in a fair and equitable manner. Now, these benefits can be money, it can be technology, it can be, for example, pharmaceutical companies can say, okay, we can donate this much of production or share of 50% or 10% of production to you if you are in an emergency. Like that, you can put agreements. So this is the idea. Now we will see how this is becoming the crux, because the rest of other things have become soft law kind of provisions. Why this is becoming a legally binding thing? Because it's not actually binding on parties. What is going to happen is it is going to bind the recipients and the providers of pathogens and sequence information. So here parties are the attempt is to obligate parties to share pathogens and sequence information of pathogens through a system or through this Article 12 system, which will give access to these pathogens and systems to pharmaceutical companies. We'll see just in the basis of a picture. So if you take up this, what I'm trying to say is this is how it works. In a country B, let's say country B is a party to pandemic agreement or PABS. There can be government laboratories, government databases, public laboratories, private laboratories, and private databases in several countries. It depends on country to country. It can be like located in a university. It can be located in research center, hospitals, medical college, etc. Right? And what happens is basically, the Article 12 or the SMTA, the PABS Annex, which is being negotiated now, actually obligates parties to designate some of them as nationally authorized laboratories or nationally authorized databases. I'm not saying this is what already there in the text. I'm just giving you a gist how it could perhaps work. And this is slightly the model in which previous systems have also worked. So these nationally authorized laboratories or databases would actually keep sharing to some other uh, uh, laboratories and databases, perhaps in another country. They become part of these national authorized laboratories all become part of a WHO coordinated system from India, from China, from South Africa, Kenya, all these countries, all these entities become partners to it. So basically, then what happens is with agreement or this authorization from the government, these organizations actually start sharing pathogens with a set of laboratories and databases. And these laboratories and databases are kind of we can say coordinated by WHO coordinated laboratory or WHO coordinated database, like that. Uh, the beauty of the system is, even if a country is not party, let's assume that US is not a party, but US laboratories can also share into the system if they become the part of the system through an agreement. Or US manufacturers can also access the system if they become I mean, it's a possibility is there, and nobody wants to exempt, very good researchers, laboratories, or manufacturers from the system. But it has its own demerits also, like in which how US might intervene in some of their process, etc. So basically, when these databases, laboratories all come together and under a WHO coordinated system, they all sign an agreement, maybe standard material transfer agreement or sign data access agreements, right? Standard agreements which is developed by parties, and they keep sharing amongst themselves. That's first part. Like, you do basic research in these laboratories. These laboratories also can be like, for example, ICMR laboratory might be giving it to Oxford University laboratory. It doesn't matter, but these people used to keep getting it as long as they are part of the system and sign this an agreement. And then you also have the proposals, actually, like the WHO biohub and WHO database also, because some countries don't have national databases, so they want an authorized database, an accountable database, a database which might listen to them, to be created within WHO. So they will also share through those databases. There will be this kind of organizations which is like biohub. Now it is, it's not very sure, it's under the WHO or under the Swiss government, etc. Currently there is one biohub which is called as WHO biohub, but it is actually a Swiss entity, a Swiss military facility, actually, a laboratory inside a Swiss military facility. They so we and the pathogens go into these hubs. The pathogens go between these that laboratories. Some of the laboratories are got separate capacities, like identified as WHO collaborating centers. Little bit more high-end analytic capacities, high-end characterization capacities, etc., exist in those laboratories. So all of these entities can be source for the participating manufacturers or pharmaceutical companies to get access to these to pathogens or sequence information, and they also have to be putting a standard agreement to receive it. So this is what we are talking about, WHO coordinated PABS system. And in these agreements, it will be obligated that whenever certain emergency happens, you will have to give these many percentages of vaccines, therapeutics, diagnostics to WHO. You might be requiring to give licenses to developing country manufacturers to diversify production during a pandemic emergency or a public health emergency, etc. There might be other proposals also, like we don't know what all benefits will be finalized, but these kind of proposals are also existing. So because of these legal instruments, manufacturers undertake certain binding obligations. So we are thinking that there will be a legal guarantee, at least 20% or 15% of real-time world production will be distributed through WHO to vulnerable sections of populations. That's the idea of PAPS. The only hiccup is, like, when a country is not a party, we don't know whether that party, that country will perhaps intervene in the execution of, like, for example, let's assume a US pharmaceutical company is part of it. They develops medicine, and at the time they have to export it to WHO, whether the US will stop it or not, we don't know. So that kind of a problem, worry is there. What happens to a participating manufacturer located in a non party to pandemic agreement. But generally, this is the idea of PABS agreement. So and there's also questions like what happens manufacturers who are not willing to participate in this system, are we excluding them from research, etc., all these questions. But it's not true. There is nothing like the PAP system is creating a closed research network. It's just saying that there will be this channel of certainty of a global pool of pathogens and sequence information. So if you are not willing to participate, you can always go back to these entities in country A and country B and collect it bilaterally, have agreements or negotiated agreements with them if you want. That's how it works. So this is about PAPS, and these are the questions which we will be addressing in the next week onwards on the negotiations. There will be some more questions, but at least these are the basic crux questions which will be negotiated from the next week onwards. Firstly, what is the scope of pathogens will be shared under this system? What do we mean by pathogens of pandemic potential? How do we identify what pathogens are pandemic potential? And only when we identify, we'll share it. Or if we don't know that this pathogen is having pandemic potential or not, will we be sharing it? Will we share it only when a public outbreak is determined, or we will be sharing 24 into 7 regularly? These are one questions. Similarly, when we share, pathogen, we talk about sharing pathogens, there will be some questions like samples, whether you will be sharing a sample of a human sample or an animal infected human's mucus, or clinical samples like of patients or animal samples, or are you going to share isolated pathogens? These are the questions they will come, in terms of what will be shared. Similarly, scope of information to be shared, like when you generate sequence information, what sort of information you will share. Like there is always a debate on metadata. Like I share the sequence information of this pathogen, but should I also ensure that I say this is from Kerala, or this is from India, or those kind of metadata information, or this is sequenced at this point of time in this laboratory? This information has to be attached or not. There is always a debate because some people don't want country of origin information, etc., to be shared, but that's not scientific, so people are pushing back on these issues. Then there is questions like medium of sharing, like I just showed you, database network, laboratory network, etc., coordinated by WHO. North do not want that. Basically Europe, etc., trying to talk about completely free decentralized system of sharing, and they are not even thinking of like whether these laboratory networks or databases has to be accountable to states or parties in general, or WHO in general. So they're trying to kind of avoid referencing to these ideas of lab networks or database networks, etc. They're putting it all under the all under the notion of open science, but we can discuss what this mean at open science. Then there is also this question of like WHO biohub, which I just said. We don't know whether this biohub is managed by WHO or Switzerland, or there will be further biohubs according to WHO Secretariat last week's briefing in different regions. And who will be owning these? I mean, whether will be owned by WHO, whether it will be owned by. So what happens like when India transfers India's pathogen to a Switzerland biohub? Who is going to own the ownership of those pathogen? Right? Whether it will be India, or whether it will be Switzerland, or whether it will be WHO, who will have some say on transactions on those pathogens? These questions will be persisting. And how will these, people accessing these pathogens and sequence information taking up certain access conditions, or how will be they taking up standard agreements? Actually, Europe, and Norway, Australia, Canada, nobody wants these standard agreements to be signed. They're just trying to avoid any reference to all these standard agreements, especially at the time of accessing pathogens and sequence information. They're saying, oh, let's make it very freely and openly available. We can ask the pharmaceutical companies to put an agreement, generally voluntarily coming to WHO, and put an agreement with WHO to give medicines during pandemic emergency. That's the only thing they want to do. They don't even want to give medicines to prevent diseases becoming a pandemic. They will only give when it is already declared as pandemic, and the disease is already spread across different part of the world. This is how some of them look at these issues. And types of benefits which you can receive, right? There's also a kind of lot of debate going on, what all benefits you need to get from this system, kind of stuff. And then, as I said, about some of the issues, which is very clearly is how do you trace the pathogens? Like when I give pathogens to WHO and from WHO it goes to a manufacturer or to several manufacturers, what happens if they misuse it? What happens if they use it for, you know, bioterrorist purposes or divert it to, some or accidentally it gets leaked and it goes to some, people, or it gets stolen by, activities like actors like terrorists, etc. What will happen? So you need to have some form of traceability tracking here, and how much you can track sequence information. Materials, okay, you track, but how much you will track information? Is that possible? Europe, etc., says it's not possible, but many other scientists from different parts of the world say it's really possible, and it is very important because nowadays you have DNA printers, benchtop DNA printers, so it's not very safe to actually give pathogenic sequence information anonymously, publicly available. This is how currently many databases are sharing it. It can be taken up anonymously by any users. So how to avoid these, that is another type of question. These are the questions they will be discussing over the next 1 year. Thank you.
Thank you, Nithin. From what you spoke, it looks like it's a one-way highway where Global South will give all its, data or information or the samples that they have, and they're not sure about receiving the, fruits of the research and science back. Because we're running out of time, I'll open it for any comments from the floor. Actually, we thought it will be a little more informal, but we didn't think you'll come prepared with a slide. So thanks again. But I'll open it to the floor. Anybody wants to say anything? Has anybody worked on any comments regarding this pandemic agreement, or in general about what you have seen during COVID and so on? We'll just open it to the floor. If anyone has, please raise your hand. Even comments is also fine, even if you don't have questions and so on. Anyone? Okay, I think there are no questions. But I'll just give one last chance. If anybody wants to comment or pose any questions, you can. We'll be sending the slides and some articles and videos if possible from this meeting.
I mean, there is nothing very good about the slide to share. I've just made it too easily.
If articles.
Yeah.
Suhas Kolekar has written, what about the cost regulation of products that are manufactured? Anything you want to comment on?
Sundararaman sir, you would like to?
I think there's nothing in the agreement that when they talk access, it's implicit whether they are just physically providing access. Cost is seldom discussed. And really talking it of affordable access, we don't know actually where it operates. Not in, at the level of the agreement, I don't know where it will come in on this. But So when we say, for example, the pandemic agreement thing that so much of proportion should be made available, and for at least for 10% of it should be given free, and another 10% at an affordable cost. This is, I think, where the formulation rests. So in return for pathogen sharing, what you are promising is to only give 10% of it free. Okay. And another 10% at an affordable cost, no particular definition of an affordable cost, particular thing. And the rest of it is anyway at pricing, and it could be monopoly pricing. So it's really a bad deal at that time. Unless you are able to break the production and be able to multiply production, unless you are able to get past that barrier, and you are able to produce it in third world settings, we will never get it beyond this.
So to just to add on, what was said is 100% true that if we don't be able to diversify production, cost will definitely go up. The idea which is like currently agreed in Article 12 is that 10% donation and up to another 10% an affordable price, which will be committed for a pandemic emergency period, which means like, not at the initial
But
stages of
10%
outbreak.
of what, Nithin?
10% of the real-time production, like
Oh,
what is being produced or what is in the stockpile, um, you will get 10% of it.
okay.
So WHO, the idea is WHO don't have to stand back in the queue, stand in front of the queue, get that 10% in hand and distribute it. Not wait till the developed countries or wherever it is being produced, they will wait till their use is finished, right? That's how it has been happening now, right? Mpox, etc. Like until Europe and Canada, etc. don't want those vaccines, it has never been given to Africa. So the idea is to stop that and get it upfront. But even then, they are only so far they have only committed to give only at the last stage of emergency, not at the outbreak stage or at the PHEIC stage. And the debate or the fight from the developing countries is to increase it, like, okay, you need, or fasten it so that you get it at the outbreak stage to prevent it becoming an international concern itself. That's what they're trying to do. But I think it's slightly, some of these people are talking in terms of market, right? Like if you if you prevent it, I don't know. I don't know how it might be conspiracy, so I let not stop, not get into it. That's one thing. Second thing is they're also trying to get licenses for diversifying production as benefit sharing. So if I am a manufacturer developing a vaccine or therapeutics or diagnostics using PAP system, then from me a commitment to share licenses to manufacture is also being demanded by developing countries, and that's what they hate to give. They might even give some donations at the outbreak stage or pandemic emergency, health emergency of international concern stage, but licenses, we will try our
Sharing
best to get.
technology and all, they're not really comfortable.
Yeah.
Okay.
And one last thing is basically the approach now in the pandemic agreement is like that, whether it is public funding agreements, whether it is clinical trial agreements or PAPS agreement, pathogen access agreement, etc., etc. All these places try to put some clauses so that the manufacturers or the developers would try to be a little bit equitable. That's the approach being taken. We don't know how much it will be,
So Suhas is
yeah.
also asking on the same thing. Ideally, it should be on population demand, isn't it? Yeah. And then one person by the name Aparna has mentioned, there's the peace clause. Can you read that one?
Peace clause in Article 11 bis in Pandemic Accord could be seen as more powerful and impact-making provision than Doha Declaration from perspective of developing countries.
What is
Well,
this peace clause? First of all, you can tell them.
I can let me read the provision. Basically, it's a uh, what do we say? Hmm. It's a clause where we say when a party is taking TRIPS flexibility measures, other countries should not create
Do
questions or create problems,
problems.
like WTO dispute settlement
ISDS and so on.
or political pressure, etc. But as far as we remember, the language was also weak in 11 bis as well, or 11 each, right? It was 11 bis or something else.
Aparna, you
11.
want to speak? Anyway. Anyone else, if you want to comment on anything or ask anything? So, with this, we'll kind of close this session. Thanks both Dr. Sundararaman and Nithin for joining us. We'll share some reading material. Sorry.
Please often refers to this mutually agreed. As mutually agreed means willingly undertaken and on mutually agreed terms without prejudice to the rights and obligations of the parties under other international agreements. That as mutually agreed is supposed to actually have diluted much of what has been given with one hand can be taken away by any number of other interpretations on that. So I don't know what is particularly referred to here.
Sure.
Is that
Aparna,
footnote? It's that footnote for defining footnote 8 that defines that in the pandemic agreement, mutually agreed shall mean. That's the clause. That was the clause that was uh, agreed upon so as to get them to sign and formally declare it.
If it is mutually agreed, it's anyway
Otherwise,
peaceful
an
only.
open standoff. Both sides were not relenting. But in effect, it's neither, it's still nowhere there. It basically means a non-existent clause.
So, with this, we'll close today's session. And thanks to both Dr. Sundararaman and Nithin for joining us. It looks like it will take. Hopefully, this pandemic agreement should be done and dusted by May. But Nithin is always cautious, so he says that we never know if it will get done by May next year. So there is time, and these negotiations on this access benefit are going. We'll be happy to share some material, but if anybody wants anything, you could always mail us or message us. So thanks to you're saying something.
Yeah. Actually, this peace clause has been removed from Article 11. Now it is in the preamble that you will not take. It's somewhere in the preamble. It is written. Yeah. And please, it's like I just want to have one request. Please stay together, and let's have discussions in a regular manner, perhaps in a periodic sense, and try to put proper policy interventions nationally, locally, as well as at the international level. We can try to write letters together or meet our government entities together, etc. So please stay together and try to take it forward. Thanks. And also keep in mind that international health regulations entity like that implementation committee is going to be triggered off by mostly by before the next World Health Assembly. So you might get a chance to participate as observers and make interventions as well.
Okay. Thank you, Nithin. So if any letters or any sign-ons will come, we can always send it to them. And the last thing is, if anybody wants to be added to the larger mailing groups on access to medicines and treatments, as part of which we are doing this, you can always write to me on my email ID or message me, and we'll add you there. So thanks again to both the speakers, Dr. Sundararaman and Nithin, for joining us, and thanks to everyone who have joined us. So we'll be stopping the session here. Thank you.